we talked about ACE inhibitors, we talked about ARBs, we talked about thiazide diuretics, and then we talked about dihydropyridine calcium channel blockers. So this is the other group of calcium channel blockers called the non-dihydropyridine. So there's two of them in this group. There's diltiazem and verapamil. Hang on in 1 second. Kim has a question. When you're deciding what dose to start a patient on, do you tend to start high and titrate down, or do you start low and titrate up? So, Kim, basically with blood pressure medications, in most cases, you're going to start low to mid-range and then go up from there. Just because if you start off too high, especially with certain classes, you can really drop their blood pressure too quickly, and they can start having like orthostatic hypotension, and they can get headaches and other symptoms like that. So we try to avoid the adverse effects. We typically start low to mid-range dose depending on how high the blood pressure is and what agent we're using, and then we go up from there. All right, so the diltiazem and verapamil. Now, the reason I have all these different names listed out here is just kind of like an FYI. So I'm going to have it for a test or question or anything. I'm going to have it specific, just saying diltiazem or verapamil. I'm not going to try to stump you on whether it's sustained release or extended release or any of that. The only reason I have this on here is because this class of medications, there's so many different brand names available. So you see like diltiazem has Cardizem SR that's taken twice a day, but then there's another kind of diltiazem SR that's under the brand name like Cardizem CD or Cardia XT, and that one's only once a day. So they're both sustained release, except one's twice a day, one's once a day, and that comes from what they actually use to make it sustained release or extended release, the actual mechanism that they use. So, for instance, one version of diltiazem is a capsule, but if you were to open the capsule up, it's like 4 tiny little tablets kind of shoved into the capsule. So it's sustained release, but it's given that weird mechanism that kind of allows that release to be a little bit slower. Others they use like ghost tablets where it's got like a tiny hole in the middle of the tablet, and that allows like water to kind of pull the medication out of that opening once it's in the intestine. And so there's different ways that they actually make the drug, and so it has different brand names, and they're not all created equal. So some of them have to be dosed twice a day, some are once a day. So the reason I have this on here is make sure if you're putting a patient on one of these drugs, make sure you specify which brand name you're using so that the directions go on there appropriately. It's ultimately on the pharmacist to make sure that you get the patient gets the right one, but just make sure that it's not something that gets confused. If you send over diltiazem SR, make sure you write the right directions on there with the right brand name, otherwise the patient may not get the full dose. All right, so mechanism of action with these, they work by decreasing the heart rate, and they slow that arterioventricular nodule conduction. So this is working more on heart rate versus the dihydropyridine calcium channel blockers like amlodipine, which is dilating like peripheral blood flow and things like that. So they're working two separate ways, and that's why they are kind of kept separate. So when you think of diltiazem and verapamil, I want you to think more on the lines of decreasing heart rate, and a lot of times you see these used in things like atrial fibrillation or other arrhythmias, tachycardia, things like that. They're not used as much in hypertension. There's a couple reasons why we could potentially use those if a patient had like a contraindication or something like that, and so I went ahead and talked about them now, but usually speaking, these aren't like first line or even second or third line in hypertension unless they have some kind of a arrhythmia or some kind of condition like that happening at the same time. So adverse effects, obviously because it's affecting heart rate, it can cause cardiac conduction abnormalities, and that's really only seen at like much higher doses. Nausea, constipation can happen. If you want to make a note, verapamil typically has a lot worse GI side effects than diltiazem. So if you are putting on a patient on one of these, a lot of times you do go with diltiazem just because it's a little bit better tolerated. Both of these do inhibit cytochrome P450 3A4, so lots of drug-drug interaction potentials. and if you're, have a drug that you're giving the patient that is a substrate 3/4, definitely be aware that this is going to increase that concentration of that other drug. So if you are using a drug like a beta blocker, which we haven't talked about yet, but we will get to today, beta blockers also slow heart rate. You got to be cautious, obviously, because you have two different mechanisms that are slowing the heart rate and slowing cardiac output. So you run the risk of things like heart block and things like that. So you want to be aware that that can happen. And if you have a patient that's already on a beta blocker, definitely use caution with these. The other thing to mention is we talked about amlodipine in patients that have diabetes and proteinuria because of their CKD, and how amlodipine can potentially make that worse because it dilates the afferent arteriole but not the efferent arteriole, and so you get that increase in interglomerular pressure, which can make the nephropathy worse. And so in that case, we have to give an ACE inhibitor to dilate the efferent side of that blood flow and decrease that interglomerular pressure again. If the person cannot tolerate an ACE or an ARB, because ACE or ARB can do the efferent dilation, if a patient for whatever reason cannot tolerate or can't take an ACE or ARB, it's contraindicated for whatever reason, the non-dihydros, so diltiazem and verapamil, also dilate afferent plus efferent. So this is another option sometimes that nephrologists will use if the patient's having some proteinuria and they need to kind of relax that interglomerular pressure. They can use this if the ACE or ARB is not an option. So kind of just make a note of that. And we're not spending much time on those, but we're going to come back to them when we get to like AFib and things like that. So our next group is the potassium-sparing diuretics. So the one that you're going to see the most commonly used, I would say, is the last one on this list. So triamterene, HCTZ. And we got a question. Aaron's asking, if a patient is African American and less likely to respond to an ACE, would you jump right to giving this? So, Aaron, in that case, if it's just treating hypertension, I would typically do amlodipine, so the dihydropyridine calcium channel blocker, not the verapamil or diltiazem. You're going to get better blood pressure lowering with amlodipine. Now, if the patient was on amlodipine for their blood pressure, but then also started having CKD and developing proteinuria, kidney disease, and for whatever reason we couldn't use an ACE or ARB, then in that case we could use verapamil or diltiazem to kind of protect the kidneys and lower blood pressure at the same time. But if you're just treating an African American for hypertension, go ahead and use the amlodipine if you're only using one drug. Does that make sense? Cool. All right. So the potassium-sparing diuretics, so the one, like I said, the one that you see most commonly used is triamterene, HCTZ. So remember, HCTZ is that hydrochlorothiazide, and so it's a thiazide diuretic. The two that are actually like potassium-sparing is the amiloride and the triamterene. So the combo with HCTZ is there really for the purpose of keeping potassium levels where you need them. So the triamterene and the amiloride really aren't going to help all that much with lowering blood pressure. There's no evidence that shows that they decrease like cardiovascular risk or anything like that. They're really there to keep that potassium kind of stable. So if you have a patient who needs to be on a thiazide diuretic and their potassium starts to drop, remember we talked about when we see that, especially even if we're using an evidence-based thiazide, that if we see the potassium go below 3.5, we kind of lose those cardiovascular protective properties. And so if you need to keep the potassium stable and you don't want to put them on like an actual potassium supplement, you can use triamterene or amiloride to kind of keep that potassium stable, but you're not necessarily going to help with the actual blood pressure lowering. And unfortunately, these are in combination with the one thiazide diuretic that I hate, HCTZ. So I wish that they had if you were going to use this, I would say maybe you look at using a combo with chlorothalidone or indapamide, but in most cases this is kind of unnecessary unless the patient just for whatever reason just is having a hard time hanging on to their potassium. if you did have a patient, let's just say, I'm going to throw this out there, if you guys did have a patient that you had on a thiazide diuretic, their potassium was low, maybe you gave them some potassium supplement to kind of help bring those levels back up, and the potassium was not stabilizing, then what would you check next besides potassium? What electrolyte level? Yeah, good, Kim. Magnesium. So remember, if potassium's low and it's not stabilizing, check magnesium, because if magnesium needs to be corrected first, and then potassium will go back up. Nikki's asking about prescribing them separately, and you definitely can. A lot of times it's just not necessary, and anytime you can decrease pill burden, you're always going to be doing better. So in that case, if you just ran into a situation where you just could not keep the potassium level up, the magnesium was low, whatever, then sure, you could give them trimethoprim or amyloid, but it's just something that isn't necessary most of the time. So again, weak diuretics, and they're typically used in combination with something if you're going to use them. I already went through all this, so this is pretty easy. But avoiding in patients with CKD, so if their creatinine clearance is less than 30, make sure you're not using these, because you're not really going to get the same diuretic effect if the kidneys aren't functioning properly. And do be aware that if you have a patient that is on an ACE or ARB, or any other kind of like potassium supplement or something like that, any other drug that could potentially increase potassium, to use caution, because this is going to make potassium go up that much more. So you have to be aware, because multiple drugs increasing potassium can be a problem. Any questions about those at all? No? All right. So the next group is our aldosterone antagonists. So think back to the RAS system. First step was that renin turning angiotensinogen to angiotensin 1, then ACE turns that into angiotensin 2, and the next step is angiotensin 2 turning into or activating aldosterone. So this is kind of like that next step in the RAS system, or the RAS pathway, if you will. So the two that are available in the market, we have eplerenone and we have spironolactone. Spironolactone is going to be the one that is most commonly used, at least in my experience, but both are okay. Mechanism of action, obviously, it's competing with the aldosterone receptor, specifically in the distal renal tubules. You're going to increase sodium chloride and water excretion, except they do have potassium-sparing effects. So this is another one that you really got to watch. The patient's on like a thiazide diuretic already, and you add this to it, you got to watch the sodium and chloride, because those are both going to be decreased. But this is a good way of bringing potassium back up if you need another agent on board and you're worried about the potassium dropping too low. This is a much more effective method than using our other two potassium-sparing diuretics, like our trimethoprim, and those are kind of garbage. This one's much more effective, and it's going to have much better effect on blood pressure as well. Renal adjustments. If a patient has an eGFR or creatinine clearance of 30 to 49, you can only use 12.5 to 25 milligrams ideally. And then if it goes below 30 mils per minute, the spironolactone or eplerenone really aren't going to be that effective anymore, because the kidneys aren't functioning properly, so they're contraindicated to use below that eGFR. So, and we're going to come back to this when we talk about kind of where they fit in therapy, but I like to think of these as like my first add-on, as long as the patient doesn't have some kind of contraindication. My first add-on, if the patient is already using the combinations of the first line agents, this is another good like kind of second line add-on that will give bring at least most patients to goal blood pressure without having to add anything else onto it. So when you see here, this is the systolic blood pressure decrease of 20 millimeters of mercury. There was a study that was done in heart failure patients, and when they added on this aldosterone antagonist, they used spironolactone in that study. They saw up to a 20 millimeters of mercury drop in blood pressure. So it's definitely something that can lower blood pressure quite a bit, and so it's a good option to use if you need, like if you have someone that has like resistant hypertension. And actually, I'm going to go back to that slide real quick because I don't have it on the slide, but I do want you to make a note. If you're ever looking at like the adverse effects of spironolactone, one of the things you'll note is that it can actually cause, in males, it can cause gynecomastia, and that's for spironolactone specifically. So if you look at the actual chemical structure of spironolactone, it actually looks very similar to estrogen. And so there are case reports of patients developing, or male patients developing gynecomastia with spironolactone. So if you think back to like when we talked about acne, we mentioned that spironolactone can kind of be used like off-label and to treat acne, and it can be effective, but we only use that in females. Males, we are worried about the adverse effects a little bit more. Blood pressure, we definitely can use that spironolactone, but just be aware that that could be a potential side effect, and if a patient's already dealing with like low testosterone levels or some kind of other hormone deficiency, you'd be better off using a eplerenone than spironolactone, because a eplerenone doesn't have the same risk. All right, any questions about that? And don't worry, we are going to come back to when to use what in therapy towards the end. So, questions, comments, nothing? All right, let's talk about beta blockers. So we have a couple different types of beta blockers. We have our cardioselective. So remember, beta receptors are located kind of all over. So the heart has beta receptors, the lungs. So when we talk about our cardioselective beta blockers, that means that it's targeting beta receptors that are directly interacting with the heart. And so a couple of them that are listed there, like atenolol, bisoprolol, and then the two different metoprolols. I want you to make a little like star next to atenolol and put Corvino hates this drug with all of his soul. And we'll talk about why in a second. But I hate atenolol. If you guys prescribe atenolol when you get out of school, you're going to be dead to me. So there you go. Non-selective beta blockers, we have nadolol and we have propranolol, and we'll kind of talk about those and how they are different in just a second. But so mechanism of action here, obviously blocking those beta receptors in the heart, which is going to slow down the heart rate. And remember, if you think about that blood pressure equation where we have cardiac output times total peripheral resistance, if you're slowing down the heart rate, you're slowing down cardiac output, which in theory, and we're going to get back to that in a second, but in theory you would be lowering blood pressure. That being said, and we're going to talk about why in just a second, but that being said, beta blockers definitely should not be used as first-line antihypertensive agents if you're only treating hypertension. Now, if the person has had like an MI, if they have heart failure, if they have angina, different things like that, then absolutely they can be used to decrease blood pressure a little bit as well as treat that other underlying condition. But if you have a patient with just primary hypertension, that's all you're treating, save beta blockers for way down the treatment algorithm. Adverse effects, bradycardia, dizziness, can cause some cold in the extremities. So if you have a patient that has like Raynaud's phenomenon or something like that, it can make that worse. It can cause some fatigue in patients when they're first starting it especially. Because of the bradycardia risk and things like that, when you are putting a patient on a beta blocker, you typically are going to start with the lowest dose and then slowly over every week or 2 weeks titrate them up. So they say start low and go slow. That is because the risk of adverse effects goes up pretty quickly if you bump up the dose too quickly or start them on too high of a dose. Some drug interactions to think about. Amiodarone, which we haven't talked about yet, but when we get to AFib, we will definitely spend a lot of time with. It can interact there, and that's just because it can enhance the bradycardiac effects, so it can lower that heart rate even more. Rifampin, which remember when we talked about like the tuberculosis and things like that. Rifampin actually increases the metabolism of beta blockers. Several of them, not all of them, but just kind of remember in general, it can potentially increase that metabolism. Smoking can also increase the metabolism of beta blockers. So if you have a patient that has been smoking and they're on a certain dose, if you all of a sudden stop smoking, you could potentially get more bradycardia because all of a sudden there's more concentration of that beta blocker in the system. So kind of be aware of that. We don't often think of smoking as causing drug-drug interactions, but it definitely can. Alright, to mention a couple other beta blockers, we have what we call our mixed alpha and beta blockers. So we have carvedilol and we have labetalol. So both of those are going to block not just beta blockers, because they're considered beta blockers, but they will also block alpha receptors as well. And so that's going to come into play when we talk about their place in treatment of hypertension in just a second. But those are the two that are alpha beta blockers. And then we also have a newer agent called nebivolol that is a beta blocker, but it also has it kind of produces nitric oxide in the periphery, which vasodilates. And so you kind of get a little bit better blood pressure lowering with a drug like that because you're dilating the periphery as well as decreasing the cardiac output. Let me look at my next two slides because I want to get ahead of myself while I'm talking. Okay, so beta blockers, like I said, there's a lot of patients that are on beta blockers strictly for the purpose of hypertension, and that is really not an ideal situation. One, we don't have any good studies showing that beta blockers actually reduce cardiovascular events like we do with like ACE inhibitors or ARBs or anything like that. So definitely not considered one of those three first-line agents. And then as far as even second or third line, it's a lot of times not recommended either unless we've tried things like spironolactone. And the reason for that is if you think about the equation again, so blood pressure equals cardiac output times total peripheral resistance. If I am blocking beta receptors and I'm decreasing the cardiac output, norepinephrine in the system still has to bind to the androgenic receptors. So alpha receptor is the only thing that's open at that point. And so alpha receptors in the periphery, if we get binding to those receptors, we're going to cause vasoconstriction. And over time, even though you're getting a decrease in cardiac output, you may actually start to see total peripheral resistance go up, which then can offset the effects of the blood pressure or the blood pressure lowering effects of the beta blocker in the first place. And so the guidelines really recommend saving this to almost like fifth line as far as treating for hypertension, unless they have some sort of a different indication for a beta blocker. So like I said, heart failure, they've had a MI, they have coronary artery disease, they have angina, something like that, then beta blockers will be fine because you're treating both conditions. But as far as just purely their ability to lower blood pressure, there's much better options, and we don't have any data showing that they actually reduce cardiovascular events. And always that should be our main focus is can we reduce cardiovascular events versus can we just lower the blood pressure. I did say that the labetalol and carvedilol are alpha beta blockers. So if you are going to use one of these for blood pressure lowering only and they don't have another condition you're treating, I definitely would advise using one of those two because you're blocking the beta receptors and the alpha receptors in the periphery. So you don't have to worry about total peripheral resistance going back up over time. So you can kind of, get that blood pressure lowering effect. Still not no evidence that shows that it reduces events, but those are definitely the two better options as far as getting overall blood pressure decreased. Use caution in a patient that has COPD or asthma if they are on a rescue inhaler that works on beta receptors, which we'll talk about all that when we get to the pulmonary section. But if you have a patient that's using a rescue inhaler and you're using a non-selective beta blocker, there's a thought that you could potentially decrease the effectiveness of their inhaler. So whether or not that actually plays out clinically is kind of debatable, but if you have a patient on a cardio-selective beta blocker, that's usually the better option if the patient also has COPD. And then if a patient has diabetes, especially if they are on one of the alpha beta blockers, warn them about the signs of hypoglycemia or low blood sugar. because what we typically tell patients to watch for is like an increased heart rate, kind of being jittery, shaky, nauseous, sweaty, things like that. But if you're on a alpha beta blocker especially, you lose your effect for your body to feel that like increased heart rate or the shaking or those types of symptoms of hypoglycemia. So there's patients that have been on labetalol or carvedilol, then their blood sugar dropped, and you are not able to actually sense that your blood sugar is dropping. So just warn patients about that. It doesn't cover up all the side effects, so like sweating and things like that still happen, but you just have to make sure patients are aware, especially if they're on like insulin or things. Kim's asking what category of beta blocker is bad with the rescue inhaler. So it's going to be your non-cardioselective. So like your propranolols and things, because you're blocking the beta receptors in the heart and as well as the lungs. And the whole point of the rescue inhaler is to activate the beta receptors in the lungs. So if they're blocked and you can't activate them, then you're not going to get the same benefit, the same bronchodilation as you would without that beta blocker being present. And then again, if you are, just like I said earlier, if you're starting a beta blocker, start low and then continue to go up slowly. If you are stopping a beta blocker, titrate them off slowly as well, because you don't want to. Does alpha have any effects for the lungs? No. So it's really just the cardioselective. Alpha receptors don't really play a role there. I know. Sorry, can you guys still hear me okay? There's a lot going on in the background. Okay, so with beta blockers, if you are stopping a beta blocker, make sure that you titrate them off slowly. Don't just stop them abruptly, because you can get this really bad rebound, like tachycardia. Your blood pressure or your heart rate rather will tend to kind of jump back up because all of a sudden that blocker is no longer there at all. So bring them down slowly, titrate them off. Can you tell them to keep it down just slightly? Thanks. All right. So I mentioned atenolol, and then I hate atenolol, and you guys will hear me talk about that a lot. So this is kind of like the study that I always use to back up the reason for that. So there was a meta-analysis that was done that looked at atenolol versus placebo, as well as atenolol versus other antihypertensives. So what they found at the study, and this included 17,000 patients plus, 19 different trials were included, and what they found was that when you compare atenolol to placebo, when you look at like the chances of the patient having like an all-cause mortality, cardiovascular mortality, there's no difference between the patients in the placebo group versus atenolol. So atenolol will bring down your blood pressure acutely, but it does not decrease the events whatsoever when compared to placebo. And then when we compare it to any other antihypertensive, so all of our first-line agents and all that, we actually get an increased risk of having an event. So all-cause mortality risk, number needed to harm, which means for every patient that we put on atenolol versus any other antihypertensive, we actually increase their chance of death. Number needed to harm is 111. So every 111 patients put on atenolol, one person dies that didn't have to die. Cardiovascular mortality, number needed to harm was 143. And then to increase chances of stroke was 77, number needed to harm. So compared to any other antihypertensives, I'm going to try to stay away from this drug when I know for a fact that it's going to not only not lower my risk, but potentially increase the patient's risk of having an event. So one argument that you'll hear a lot is, well, it's going to lower the blood pressure, and blood pressure being elevated is what actually leads to those events, so who cares what agent I'm using? Well, this is one study that shows that that's not always the case, because yes, you will get blood pressure lowering with atenolol, but it's definitely not a good option, and you should highly recommend staying away from this one. Yet there's a whole bunch of patients that are on atenolol still. It kind of blows my mind. All right, any questions about beta blockers? All right. So let's talk about the alpha blockers. So these are just strictly alpha blockers. They don't have any beta activity. There's doxazosin, prazosin, and terazosin. The one that you will see most likely is doxazosin. That's the one that you typically see being used in blood pressure or for hypertension, rather. Remember when we talked about that all-hat trial where we compared lisinopril, amlodipine, and chlorthalidone? There was a fourth arm to that study that had doxazosin in it that was actually stopped early because the increased risk of heart failure was seen in that study, as well as the other cardiovascular events were not being decreased compared to other drugs. So they stopped that arm and discontinued it, and they kept the other three going, which is why doxazosin is definitely not a first line or even second, third, fourth, fifth line option, in my opinion. I try to save this strictly for like sixth line. Honestly, I can't remember the last time I've ever recommended using this drug to any of the providers that I work with. So doxazosin is definitely one that I'm not a fan of. Sometimes you will see people using this if the patient has like BPH, so guys that have enlarged prostates. This is a class of medications that you can sometimes use in that case. However, they have much better options that are more specifically targeted for alpha receptors dealing with the prostate, and that's that system. And so those options are a much better go-to as far as treating BPH, as opposed to trying to kind of kill two birds with one stone and give doxazosin to help with hypertension and with BPH. That is a tactic that some people do, but a lot of the research kind of pushes people against that, and I've heard a couple urologists that have said that they try to avoid doing that unless they just absolutely have to, just because doxazosin is not a good blood pressure lowering agent. So we've talked about spironolactone was one of the aldosterone antagonists. We talked about doxazosin now, and bisoprolol was a beta blocker, a cardioselective beta blocker. There was a study done called Pathway 2 that compared all three of those agents, and what they were looking at was patients that have already been put on either an ACE or ARB plus a thiazide plus a calcium channel blocker. So they're on all three first-line agents, and they're still not at goal blood pressure. What is like the best fourth-line agent to add on to those patients for like what we consider like resistant hypertension? And so the Pathway 2 compared all three of those drugs to see which class was kind of the best, and spironolactone won by a landslide. It was much more effective at lowering blood pressure than the other two agents, and the newest hypertension guidelines actually quote Pathway 2 when they are given recommendations about which agent to use fourth line. So they actually say to go ahead and use spironolactone as long as the patient doesn't have any kind of contraindication or anything like that. They encourage you to use spironolactone over a beta blocker or doxazosin. And again, we'll come back to the treatment algorithm towards the end, but alright, so alpha blockers, so doxazosin, those drugs, they're going to work by inhibiting that uptake of catecholamines, so like norepinephrine, things like that, in the smooth muscle cells that are found in the peripheral vasculature. So basically causing vasodilation, which will lower the blood pressure because you're lowering the total peripheral resistance. But again, remember, increased risk of things like heart failure and other conditions, not first line. So yes, they will lower blood pressure, but they're not ideal. One thing to keep in mind is there's something called first dose phenomenon, which is this like transient dizziness or faintness that happens with the first dose. Can cause like palpitations, and it even causes that syncope like that, like within 1 to 3 hours of the first dose. So make sure patients are kind of aware of that, especially with their first dose. And then the orthostatic hypotension can be persistent, especially in elderly patients. It's another reason why we don't like these drugs as much. The orthostatic hypotension definitely increases the risk of a fall in an elderly patient. And so if you have a patient that's on one of these drugs for whatever reason, make sure that you tell them to, if they've been laying down or sitting down for a period of time, to kind of get up slowly as they are once they've been sitting for a period of time. Adverse effects besides that, we have things like vivid dreams. It can even cause some depression symptoms in patients. Because it crosses the blood-brain barrier, that is kind of a risk. It's not always the case, and in fact, there's cases where we use these in like PTSD and things like that to help with nightmares and things like that. So it does affect dreaming and things, but not always in a bad way necessarily. And then it can cause priapism as well. So males definitely need to be aware of that. If they start having any symptoms, they need to let y'all know if you've started them on one of these agents. Any questions about those alpha blockers? Hannah, say my uncle sometimes uses propranolol in surgery. No, if it's just a matter of like keeping the patient calm, relaxed, lowering the heart rate, like kind of that, no, there's nothing wrong with that. Especially like propranolol, you'll see sometimes used in like if you have anxiety, like stage fright type of things. I've seen, I don't recommend this, but I've seen some pharmacy students that I've mentored for their like grand rounds where they have to like present their research at the end of their fourth year. I've seen them use that to kind of like keep themselves calm and like not have stage fright. And then like you're saying he used it for himself. Yeah, so that's another thing. People can do that to like kind of just keep calm and kind of, for lack of a better word, mellow out. I would if a patient's using that for that particular reason, I would say make sure you do a trial run of that before you actually do the activity that you're trying to keep calm for, because it kind of backfires on people, which is why I don't usually recommend students trying that for presentations and whatnot. But it's definitely not anything wrong with doing it that way. Any other questions about the alpha blockers? All right, so the next group is also working on alpha receptors, but these are actually working on like centrally located alpha-2 receptors, and so these are agonists. So these are activating those receptors, which is going to kind of calm down like overall central nervous system and keep in theory, bring down blood pressure and things like that, because you're getting less like sympathetic nervous system activation, so that you're slowing down that fight or flight type thing. Clonidine is the most commonly used in this case. This is a drug that I'm really not a fan of as well. Sometimes you'll see this used for like if the person comes to the clinic and their blood pressure is through the roof at their visit, they'll give them a clonidine like in the office to see if they can get their blood pressure lower before they leave. There's actually studies now showing that amlodipine is actually more effective than using clonidine in that particular situation. But really, it's one of those things. Again, I would save this for like more like fifth, sixth line option. But there are patients that are put on this first or second line, and if there's no evidence that it reduces cardiovascular events, that there's a lot of more side effects to worry about. So not a great option. One that you will see sometimes is called methyldopa. That was the blood pressure medication of choice for a long time for pregnancy, and now it has actually been replaced with labetalol as far as first line. But when you're treating a hypertension in pregnancy, like you absolutely can't use ACE inhibitors or ARBs because they're category X if you go by the old pregnancy categories. So they're completely contraindicated. And methyldopa for a really long time was the drug of choice for hypertension in pregnancy. It's kind of second line now, but yeah, that's usually the only time you'll see that drug. Again, potentially could use it like fifth or sixth line, but not a great option to reduce outcomes or anything. All right, so again, these are going to work on those alpha-2 receptors specifically, and I've already talked about decreasing that sympathetic nervous system activity. Nikki said I cut out for a second, and the first line for pregnancy. So first line, and we'll come back. I'm actually going to come back to a slide on pregnancy at the end, but first line now is typically labetalol, that alpha beta blocker. That's been the one studied and shown to be safe and efficacious during pregnancy. And then methyl-dopa is also an option, but it's been moved from first to kind of second as far as how widely it's used in pregnancy now. But typically speaking, if you see methyl-dopa, that's usually where you're going to see it at, is in pregnancy. So adverse effects for clonidine and methyl-dopa, sedation is definitely one. You'll see sometimes kids being put on things like clonidine to treat like ADHD because it can kind of calm them down a little bit. So you'll see that kind of used, but can cause sedation, can cause dry mouth, even depression. Orthostatic hypotension is definitely a risk, and same kind of thing with like beta blockers. You want to avoid like abrupt discontinuation, so you can get a really bad rebound hypertension. So it's good to kind of like wean them off slowly over a couple weeks or a few weeks to make sure they don't get that rebound hypertension. Any questions about those at all? All right. So to talk about loop diuretics. So I put these in here just because we're going through a lot of the different medications used in cardiology. The loop diuretics are not like indicated specifically for lowering blood pressure. You might get some blood pressure lowering with them, but they are really there to get rid of fluid that's the body's retaining. So they're there for the sole purpose of kind of diuresing. So you'll see these used more like in heart failure and things like that to kind of get rid of that excess fluid. The blood pressure lowering effects are kind of like minimal, and they're not indicated specifically for hypertension. Although, again, like anything else, you will see patients that are being put on loops specifically for hypertension for whatever reason. They are going to work in the loop of Henle. That's why they get the name loop diuretics. They're going to block that reabsorption of sodium and chloride, and that's going to lead to obviously more excretion of water, sodium, and the other electrolytes. So this is going to have the same kind of effect as thiazide diuretics, except you are going to decrease calcium instead of increase calcium like you do with a thiazide. But you're still going to get a risk of decreasing sodium, potassium, chloride, all those things, and we see a decrease in calcium as opposed to thiazides. You get an increase in calcium. That's kind of the way I keep those two straight, is based on their calcium, because the rest of them they're kind of in sync. So again, typically not used in hypertension unless you need to diurese the patient, and again, that's coming directly from the guidelines. They don't want you using these just for primary hypertension. They do have a sulfa moiety like at the center of their chemical structure. So if a patient has like a true sulfa allergy, you have to use caution, especially if they have like a hypersensitivity, like an anaphylactic reaction to sulfa. You can't use loop diuretics, except for one, which we'll talk about in 1 second when I show you the list of them. Let me see if did I give you a brand name list? No. Okay, I didn't. So I will. I'll put up another slide so that you can have the brand names of these drugs, just so you see them, because we're going to go back through them with heart failure next week. But just so you're aware. So if the patient has a sulfa allergy, and like I'm talking a true like anaphylactic reaction to sulfa, the one that I want you to use is the one at the bottom called ethocrinic acid. I have only seen that used one time, and the patient that we had to use that in was a patient that had literally had anaphylaxis when they took one dose of furosemide. And so found out they had a sulfa allergy. There was a true sulfa allergy, so any sulfa-containing drug was going to put her in the hospital. And so we had to use ethocrinic acid for that patient. But that's one that almost never gets talked about. But it's a little bit more expensive and all those things, but I would save that strictly for that patient population. It's going to be very rare that you end up having to do that, but just in case that you run into that, I want you to at least be familiar with it. And if you are trying to convert from one or the other, bumetanide 1 milligram equals torsemide 20 milligrams equals furosemide 40 milligrams equals ethicronic acid 50 milligrams. So if you remember 1, 20, 40, 50, that's kind of an easy way to keep it straight, and then you can do math if it's a different strength. So if you're using 2 milligrams of bumetanide, you can just double the other ones and kind of get there. But that's the conversion that I have memorized, and that I kind of use if I need to switch between. Also, if you want to jot down, and we're going to come back to this in heart failure, so I don't expect you to memorize this now, but if you want to jot it down, this is the oral dose of these agents. And so if you have a IV dose and you're switching to oral, all of them are a 1-to-1 switch except for furosemide. So furosemide is 1 to 2, so you have to double the dose if you're going to the oral version from the IV version. All the other ones 1-to-1. So if you're using 1 milligram of bumetanide with IV, you can switch to 1 milligram PO or oral, and that'll be the same dose, same bioavailability, all that. But again, I mentioned this here because I want to at least bring it up now since we're talking about drugs. But we're going to come back and really talk about this during heart failure. Can I repeat what I said about Lasix? So for everyone who is, if you ever have a patient that's taking IV loop diuretics, so if they're on IV torsemide, IV furosemide, whatever, and you're switching them to the oral version, all of the loop diuretics have a 1-to-1 conversion from IV to oral. So 1 milligram of bumetanide is IV is equal to 1 milligram of bumetanide oral, except for furosemide. Furosemide is the one exception. So if you're going from IV to oral, you have to basically just double the dose of what you were using for IV. But that only applies to furosemide, and even that's actually a little controversial because there's some thought that may not even be the case. But the textbook answer to that is you have to double the dose of furosemide only. Kathleen, Kim, does that make sense? And then Hannah saying 2 grams IV. So, no. But, so basically, if you're giving like 40 milligrams IV Lasix, that would give you, you'd have to switch to 80 milligrams to get the same dose PO. So when I say 1 to 2, I mean like half the dose IV or double the dose if you're switching to oral. Does that make sense, Hannah? Gotcha. Okay, yeah. Okay. All right, cool. All right. Any questions about the drugs themselves? All right. So one thing that I want to make sure we talk about is when to kind of dose some of these agents. So we talked about like normal circadian rhythm and patients that are quote unquote dippers versus non-dippers. So typically speaking, we think of blood pressure kind of being decreased overnight in dipping, but we found out as these studies kind of came about and they were looking at patient populations that that's not always the case, and there's actually a big majority of patients that, I shouldn't say majority, there's a big number of patients that actually have their blood pressure go up while they're sleeping and not down like we always assumed. So there was one study that came out called MAPEC, and it basically showed that if a patient is on, I think they used 3 or more medications for blood pressure, that if you dose at least one of them at night, then you actually can decrease the chances of mortality in cardiovascular events instead of dosing all of them in the morning. You also get an improved blood pressure control when you dose one agent at night to help out the patients in the population that are considered like non-dippers, quote unquote. There was another study that was done, I think IGEA came out last year, 2019, and they kind of showed in a much bigger version of that you reduce cardiovascular events when the blood pressure was, at least one blood pressure medication was taken at nighttime versus the blood pressure, all the meds being taken in the morning. And the way I kind of do it personally, and this is more just my method of doing it, so if I have a patient, let's say they're on amlodipine and they're on lisinopril, if I don't know whether or not the patient is a quote-unquote dipper or non-dipper, what I do is I typically dose the amlodipine in the morning, and then I dose the ACE inhibitor at night. And the reason for that is, one, because if I dose one at night, I'm covering the patients who do happen to be non-dippers and their blood pressure goes up at night. I'm giving them like a fresh dose of their medication right before they go to bed. And the reason I picked the ACE or ARB is because, one, a lot of studies that have showed their protective properties, their effects in patients with like diabetes and things like that have all been dosed at night, as well as the RAS system itself. It has a higher physiological response at night. And so if I'm blocking that ACE inhibitor in the RAS pathway, I can dose it at night and get a little bit more bang for my buck, if you will. So that's how I typically do it. Again, like according to like MAPEC, they don't really say which one you have to dose at bedtime, but they say if a patient's on multiple meds, dose at least one of them at bedtime to account for them being dippers or non-dippers. All right, so back to the actual treatments that are indicated for hypertension, kind of step by step. So first line options, if you have a patient that has literally no comorbidities, primarily like you're just treating hypertension, nothing else is going on, you can pretty much pick your choice of medication, either ACE or ARB, or a thiazide diuretic, or a calcium channel blocking agent. One of those three agents. If it's an African American patient, typically start with the calcium channel blocking agent because that's going to give you a little bit better blood pressure response. Other than that, though, you really can pick any one of those three agents. If you need a combination of those two agents, even as first-line therapy, again, there's no set way to choose other than looking at comorbidities and seeing if the patient has any other indication for one over the other, and then making sure you're not using an ACE and ARB together. Try to avoid that as best you can. So you're picking ACE or an ARB, and then you're adding on either a thiazide or a calcium channel blocker or a different combination, but those are the kind of set combos. So thiazides can be used first line in African Americans. We typically say calcium channel blockers are the most effective, and they're definitely more effective than ACEs and ARBs in African American patients. So it's not wrong to pick a thiazide diuretic either, but if you're just treating hypertension, African American patient, typically save ACE inhibitors as like add-on. Don't start that as monotherapy. So let's say you put them on one of those three classes and the patient's blood pressure is not controlled, and you need a second line option or even third line option. You just use a combination of 1 to 3 of those agents above. So before you even look at all the other drugs we talked about, the patient should be on either an ACE or ARB plus a thiazide plus a calcium channel blocker like amlodipine. So unless there's some kind of like a contraindication, unless there's some kind of reason why they can't be on one of those three, we try to use a combination of those three agents before we even look at the other things when we're treating just hypertension by itself. Things get a lot more tricky when you start talking about heart failure or post-MI and things like that, and you kind of mix it up a little bit. When you're talking about just hypertension, you should be using a combination of one of those three agents, using all three before you move on to the other classes. And even then, if you have a patient, let's say you have a patient that is on lisinopril, once at bedtime you have amlodipine in the morning and you have hydrochlorothiazide in the morning. You're on all three evidence-based, or not evidence-based, but first-line agents, and the blood pressure's still not controlled, before adding on a fourth line agent, the guidelines now recommend one, splitting the ACE or ARB dose if you can. So instead of doing 40 milligrams of lisinopril at night, splitting it to 20 milligrams in the morning and 20 at night, because again, a lot of the ACEs and ARBs have a 12-hour half-life, and so if you dose it twice a day, you're kind of dosing on the half-life. It's not always necessary. Some patients should do just fine on 40 milligrams once a day, and then they don't have to take something two different times throughout the day, which makes it a little bit easier for adherence. But if you're having resistance, then split the dose of the ACE or ARB, as well as making sure you're dosing the ACE or ARB at night, or at least one of the agents at night if you're not already. And then if the patient is on hydrochlorothiazide as one of that 3-drug combo, switch them to chlorthalidone or indapamide, which are 2 evidence-based thiazides, before we actually add on a fourth agent. Because hydrochlorothiazide, we know, doesn't lower blood pressure as much as chlorthalidone or indapamide. So make that switch first before adding on a fourth line agent. So if you're trying to figure out if the patient is on, what the patient needs to go to next, if they're on lisinopril and amlodipine, you need to make sure you add a thiazide diuretic before even looking at the other classes, unless there's some kind of contraindication. If they're on a thiazide diuretic and they're on amlodipine, add on the ACE or ARB before you look at the other agents. So always making sure those 3 drugs that are considered first line are all being used in combination before we move on. Does that make sense to everybody? Cool. All right, so again, if we have those 3 drugs being used and we need a fourth line agent, so it's like resistant hypertension, we need another drug, you have verified they really are taking their medication, they're not just lying to you, which definitely happens. Picking which drug we're going to use fourth line, again, depends on the patient, because we have to take into account their labs and their comorbidities and all that. But ideally, we want to use an aldosterone antagonist, because remember, if we looked at that Pathway 2 trial, which showed that spironolactone was more effective than the beta blocker and the alpha blocker at lowering blood pressure. So spironolactone or eplerenone is a good add-on fourth-line agent to add on to those 3 first-line agent combinations. And so spironolactone would kind of be the next piece of that puzzle. And then if the patient still is not controlled, fifth line, I typically consider carvedilol or labetalol, or nebivolol, but that's more expensive. So carvedilol is usually the one people go with, because remember, it's alpha and beta blocking properties, so you're going to get better blood pressure lowering as opposed to one of the other beta blockers. And that's, again, coming directly from the guidelines. They say that if you're going to use a beta blocker in this setting where you're treating it as fourth or fifth line, use carvedilol or labetalol to get the optimum blood pressure lowering, because you're blocking both alpha and beta receptors. And then sixth line, first of all, if you need 6 agents to get the blood pressure lowering, most likely something else is going on, and you probably need to call the pharmacy to see when the patient actually picked it up, because they're most likely lying to you if they are still not controlled with their blood pressure at that point. But there are cases where patients really do need that many drugs. So 6th line, you can use really any of the remaining classes of medications that we talked about that you haven't used already, and then just watch for side effects and all that. But that's usually, once you get to 4th and 5th line drugs, if you're not working directly in cardiology, let's say you're doing primary care, family medicine kind of thing, you probably need to refer out at that point, because it's not common to see a patient that's on 3 or 4 drugs and still not have controlled blood pressure. So, check adherence and potentially refer out to cardiology to see what else is going on. Kim said, do you only split the ACE or ARB if they're taking the max dose? That's typically what I personally do. I save kind of splitting the dose for patients that are not at blood pressure goal, even though they're on max dose, or at least max tolerated dose of an ACE or ARB once a day. if it's not enough to control them before I add on another agent, or especially if they're on a combination already, I usually split the ACE or ARB at that point to try to maximize the benefit. And the only reason I say that is just because I try as hard as I can to simplify patients' regimens. And so if a patient can have their blood pressure controlled on 40 milligrams of lisinopril once a day, then I'm good with that. Like, I don't have to split it. I know they'll get a little bit better blood pressure lowering, but if they're already controlled, then I don't need to necessarily go any lower. So I kind of save that as like a strategy to reduce adding on more agents. Kathleen asked what the half-life is. So lisinopril specifically, and again, I always bring that one up because it's one of the most commonly used ACE inhibitors, but it's 12 hours. So if we dose it on the half-life, which is what we technically should be doing with our drugs, we're dosing it twice a day. The duration of action may last, or the effects may last longer than 12 hours, but the true concentration in your system, the half-life is only 12 hours. Kim's asking, how long do we give these agents on a new regimen before you check to see if it's working? So it depends on how high their blood pressure is. Usually I give it a month or so on a new regimen to see how they do, make sure they actually take it. If it's really high blood pressure, then I may bring them back in 2 weeks and reassess. And then if anything, bump up the dose. I usually am not adding on agents. I would wait like a month or two before I would add a second agent or something like that. Any other questions before I talk about this trial? Would alpha blockers come into play as fifth line possibly? They could. They just have more side effects, typically speaking, especially like the doxazosins and things. And since carvedilol will help with blood pressure, I'd rather use that personally, just because doxazosin has that data showing that it can increase risk of things like heart failure and whatnot in some of those big studies. So I personally save it for like sixth line, but yes, it could potentially be used as a fifth line option in some patients. All right. So I know we've been going through a lot of studies and things, but this is probably the most important study that I kind of want you to have in the back of your head, because an argument that you will hear a lot of times, and I've heard this listening to continuing education conferences and things like that. There are some healthcare professionals that think as long as you lower blood pressure, who cares what agent you use? I'm just there. I've even heard a PharmD that was given a talk saying that he uses atenolol at his clinic because as long as he lowers the blood pressure, who cares? And the cardiologist that kind of brought up the evidence to the contrary actually brought up this study. And Accomplish was a trial where they took benazepril and amlodipine, and they compared it to patients that were taking benazepril and hydrochlorothiazide. And they were looking at a reduction in cardiovascular events. So the study was supposed to go 5 years. It only lasted 2 years, and they stopped it early because they saw a statistical difference between the two groups at that point, so they stopped it early. The first thing that they kind of noted was that the blood pressure was the same in both groups. So it didn't matter which group the patient was in, they got to the same goal blood pressure. So when you first look at that, it's like, okay, well, I guess it doesn't really matter which agent we use. That being said, when you looked at the actual outcomes, so cardiovascular mortality, MI, stroke, all that, they were decreased. The risk of one of those cardiovascular events was decreased in the patients getting benazepril and amlodipine. And so the moral of that story, and the reason that trial is quoted a lot, is because we want to make sure that we're treating the patient for outcomes, not just blood pressure lowering. Because if I decrease blood pressure and the person ends up having a stroke, I didn't actually help that patient. Blood pressure is just a number. So treat the patient, not the numbers, is the moral of that story, and Accomplish is kind of the big data that everybody quotes to justify that theory. All right, almost done. Hang in there with me. Blood pressure in diabetes patients, I'm going to have this in here. We're going to get back to the reasoning when we talk about diabetes in a few weeks. So I'm not going to, I want you to kind of have this as just FYI for now. But the newest guidelines have changed again, where initially blood pressure goals in patients with diabetes were still the 140/90, like the JNC8 had and all that. But they've also been lowered to 130/80. And there's some data and stuff that shows why, and I'll explain all that when we get to diabetes. But for time's sake, I'll hold off on that now, and I don't want to cause confusion. So these next two slides, I want you to kind of just mark FY, and we'll talk about them when we get to diabetes. But the Accord trial, we'll come back to. This slide here, hypertension in pregnancy. The ones that I want you to make note of is the methyl dopa and the labetalol.
You gotta be kidding.
Hey, sorry guys, hang on, there's a lot of stuff in the background. Okay, so labetalol is the first line agent. Methyl dopa is kind of second line. And the other agents are going to be either on this chart because they're saying they're contraindicated or because we don't have good data showing that they're safe. So in pregnancy, if you're treating hypertension, labetalol first line, methyl dopa is another option that has a long-term safety data, and it's also a preferred agent if the person can't take labetalol. But those are the two that I would recommend for hypertension. And then obviously OB is going to be following these patients as well and helping with the hypertension management. All right, and the last thing is, again, looking at the big picture, and you're trying to figure out which direction to kind of go with. If a patient has other comorbidities going on, then look at those before kind of adding on, like deciding which first-line agents you're going to use. If it's just hypertension, you can pick any of those three agents in most patients. However, if the patient has something like heart failure, which we're going to get to next week, we're going to use an ACE plus a beta blocker, kind of like first line. Post-MI, we're using a beta blocker, at least for the first few years, plus an ACE or ARB. Diabetes, if they have kidney disease, especially on top of their diabetes, we're using ACE or ARB as preferred. And then if the person's had a stroke, a thiazide or a thiazide in combination with an ACE is kind of the preferred agent. And that's just based on the data, the different studies, and like looking at these different comorbidities and things like that. This will make way more sense as the next couple weeks kind of go on. I wanted to introduce it here. I don't expect you guys to memorize this chart. You'll have this memorized by the time we get through heart failure, MI, all that stuff, because it'll make more sense. But the algorithm that I kind of wrote out step by step on the few slides ago, that's the one that I want you to follow if it's just hypertension. If the patient has hypertension plus one of these other things, then we have to be a little bit more specific with which agents we're using first, second, third line. But again, I don't expect you to memorize this slide. This is more giving you a sneak preview of what's coming up in the next couple weeks. This will make a lot more sense later on. Does anyone have any questions about all of that?